You know, we have come to so many of the different locations of Singing River Health System and learned so many new techniques that they're doing. And today we're at the Ocean Springs Hospital branch of Singing River Health System talking to interventional radiologist Dr. Marshall Walker. How are you, Dr. Walker?
I'm
Good
great,
to see you again.
Thank you for coming back.
Certainly, certainly. Now, the first part of this segment, we're going to talk about a problem that directed to men, and that's dealings with the prostate. And what are some of the issues that you're seeing that you're having to treat here, and how are you treating them?
Well, the benign enlargement of the prostate occurs whether you want it to or not. The prostate gets larger as we age. Whether it causes symptoms or not is really the larger issue. Many men, I mean, beyond age 65 or so, probably a plurality of men have difficulty beginning a urinary stream, or you have to get up in the middle of the night and frequently urinate. Additional, male problems associated with blockage of the urinary tract also occur, and it's because as the prostate enlarges, it begins to squeeze on the tube that allows urine to exit the body. There are several different options treatment-wise for that. You can have your prostate removed surgically, although that's routinely left for surgery for cancer. But periodically, lower urinary tract symptoms are sufficiently bad that surgery is a good option there. There are also ablative techniques, not things that I do. What I do is called prostate artery embolization, and what that is going into the arteries that feed the prostate on either side of the body and choking off the blood supply to the outer portion of the prostate where the hypertrophy occurs. And it's sort of like pruning a bush. You prune the outside branches and make it smaller, and what happens is that the pressure on the urethra is resolved.
Okay.
It's an outpatient procedure, relatively painless, and one thing that men may be excited about is that there are no urinary catheters associated with that procedure.
Now, is this also a treatment for ED?
Some people have resolution of ED or improvement in those symptoms. There's certainly, it's not indicated for that procedure, but it does often occur.
Now, how did PAE come about? And why did you choose to deal with that?
Well, I embolize a lot of things. Usually it's for bleeding. And so the same technique is utilized. It's the same procedure, the same equipment is used. It's just we just got FDA approval early this year to do this procedure for this reason. So we've been embolizing prostates for years for other reasons. It just so happens that over time we discovered this sort of interesting after effect of the embolization procedure.
Right.
And so that's been fortuitous because it gives men a non-surgical option for a very, very, very common problem.
Well, how is this process better than previous treatments that have been used?
Well, I view most of the things I do, I view as adjuncts to the surgical subspecialties. This is not meant to replace anything. This is merely another option for men that may not be a good surgical candidate, or who can't undergo anesthesia, or are horrified by the prospect of having a urinary catheter for 7 to 10 days. This is an option that is very likely to help and is real low impact. It's
without having the catheter.
Exactly. Well, also, time-wise, there is no hospital stay associated with it.
And like you did mention that this is an outpatient procedure.
Correct.
Something like that. So some of the symptoms, go over those again and find out if someone thinks that they may have need of this, are hard to urinate.
Difficulty beginning the stream.
Right.
Also frequent urination. Routinely, men will say they wake up 3-4 times a night and they will urinate very small amounts and never fully relieve their bladder because there's a stricture, there's this tight spot down low that does not allow evacuation of all of it at once.
So they stand there for a while and it's just like very little, and then an hour later they're up again.
Right, and the truth of the matter is that male patients, obviously prostate artery embo is never done on female patients, but male patients are often reluctant to seek medical care, quite frankly, and so these things kind of get ignored and they go on and on and on for years sometimes.
And that could really create some problems down the line.
Right, well, and that's one of the reasons I like this, is because it's so low impact. I mean, hopefully we can reach some of those patients that are reluctant to seek therapy for this because they don't want to be cut on, or a number of reasons.
One of the other things that procedures you're doing right now is called the spine jack. Talk about that and what it's used for.
The spine jack is, we're the first, I believe I know we're the first people in Mississippi doing this, but I believe we're the first in the American South. The people who trained me at UAB were very angry at me because I did it before they did. But what it is it's a implant that goes into a vertebral body that's been fractured. It's a permanent implant, and it is a jack in much the same way that a car jack lifts a car up off the ground. A compressed vertebral body fracture, the jack is deployed in such a way that it actually elevates the bone back to where it belongs. And then, just like all vertebral augmentation procedures, bone cement is left in there to solidify it in place. But the reason why it's interesting, it's the first leap forward we've had in the treatment of compression fractures in a very long time. They've been doing it in Europe for about 10 years. The evidence is all there, and the evidence is very interesting. For people that have compression fractures, it actually reduces the rate of refracture in other adjacent bones by about 50%.
Now, what are perhaps some of the symptoms that someone may feel if they think something just doesn't feel right in my back? Maybe they've had a fall. What causes a compression fracture? Compression
fractures most of the time are caused by osteoporosis. So these are, 80–90% of them are elderly female patients whose bone density begins to decline after menopause.
Right.
And the symptoms are back pain, but back pain that doesn't get better with a heating pad or Tylenol. It's back pain so bad that it's difficult to lay down or sit up or move. Those are the types of symptoms that we look for, and then you have to prove it with advanced imaging like a nuclear medicine bone scan or an MRI, because what we find is that there are many of these fractures, and only ones that are fresh enough to move the bone are eligible for spine jack. For the ones that aren't fresh enough to move any bone, we still have treatment options, but the jack is sort of really reserved for people that have new fractures.
Okay. Now, if someone wants to find out if they're eligible for either one of these, do they need to go to their primary care physician first before they contact you?
Definitely. Most of the insurance carriers around on the Gulf Coast, and certainly Medicare, prefer a primary care doctor to be involved, and I prefer that also because those are the people who are going to be dealing with the aftercare,
right,
and seeing the people 6 months, a year from now, to monitor them for in case any of these things come back. If your prostate were to re-enlarge or you were to have new spine fractures, we want someone that knows you well and sees you regularly, taking care of that.
Dr. Walker, thank you.
You're very welcome.
I always love coming here because you find there's so many new things that y'all are doing. The world of medicine, the new technology that's, and there's no telling what we're going to see more and more down the line. Again, if you are having some issues, prostate or maybe a back fracture or something like that, contact your primary physician and see if they can hook you up with someone here at Singing River Health System.